So thank you so much for joining today's session. It is our last session of 2025. And my name is Laura Legier, in case you don't know me or haven't met me before, and I'm the Senior Manager of Public and Community Engagement at ICS. As you may know, this speaker series is a virtual event hosted by the Science Office to ensure the responsible use of race, ethnicity, and other social data at ICS. Before we dive into today's session, I did want to mention that we are evaluating this entire Equity in Focus speaker series over the past year and a half. And we would really appreciate your feedback on how you've used the content from this series or past sessions in your work, and also your suggestions for future series sessions in 2026. The link was pasted by Elise in the chat. It was also emailed to folks who've attended past series a couple of weeks back. So we'd really appreciate if you could take a few minutes and just give us your thoughts. Today, we'll focus our session on the Better Outcomes Registry and Network, also known as BORN. We will explore race-based data available at ICS through BORN and its limitations, how BORN has used race-based data to assess race-based medicine, and examine perinatal health equity issues and learn about BORN's data governance, policy, and process for the use and disclosure of race-based data. Before I introduce our two speakers today that we're thrilled to have join us, I want to open with a reflection and land acknowledgement. In reflecting on the month ahead, December 15th will mark the 10th anniversary of the Truth and Reconciliation Commission's final report, which outlined the steps towards healing and reconciliation between Indigenous and non-Indigenous peoples in Canada. The TRC spent 6 years traveling to all parts of Canada and heard from more than 6,500 witnesses, many of whom were residential school survivors. In 2015, the TRC released its final report along with 94 calls to action to guide Canada's path towards reconciliation. While progress has been made in meeting some of these calls to action and achieving other milestones over the past 10 years, there's still work to be done towards realizing all the calls to action. Individually, in our own path towards reconciliation, consider continuing to educate yourselves and others about Indigenous-led work, literature, and art, and support Indigenous-led events and initiatives in your local community. In terms of the land we're presenting on today, Toronto is covered under Treaty 13 and the Williams Treaty, and is the traditional territories of many First People, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. This territory is part of the Dish with One Spoon Wampum, a treaty made between the Anishinaabe, the Mississaugas, and the Haudenosaunee, where nations entered into it to protect the land and responsibly care for its resources in harmony together. I'm now pleased to introduce our speakers for today, Dana Hall and Dr. Grace Niam. Dana Hall is a certified genetic counselor with Prenatal Screening Ontario, or PSO, housed within BORN. She's a white settler, cisgender woman residing in Kingston, Ontario, on the traditional territory of the Anishinaabe, Haudenosaunee, and Huron-Wendat. Dana is co-chair of BORN's Internal Health Equity Advisory Group and was the 2023 president of the Canadian Association of Genetic Counselors. Prior to her role with PSO, she worked for 13 years in the General Genetics Clinic at Kingston Health Sciences Centre, where she was the inaugural lead genetic counselor and adjunct to the professor at Queen's University. Dr. Grace Meow is epidemiologist at BORN Ontario and an investigator at Cheeto Research Institute. She is also a member of BORN's Internal Health Equity Committee. She holds a master's and a PhD in epidemiology from Queen's University and received training in clinical medicine from China. Her research focuses on prenatal health, congenital anomalies, and the social determinants of maternal and child health. She currently leads several projects related to congenital heart disease and health equity in maternal and child health. I'm so pleased to now hand it over to our speakers to tell us today about BORN. Thank you both so much.
Thank you so much, Laura. We're so excited to be here today. And as you already mentioned, I think it's really important for me, especially to acknowledge in this work that I am bringing the lens of a white cisgendered settler. And I'm continuously engaging in learning, listening, self-reflection, and engagement with equity-deserving groups to position myself as an ally in this work. And so these are the learning objectives that Laura has already mentioned today. And so this will be the session overview. We will divide our session into 3 sessions. First, speaking about the data from BORN that goes to ICES and specifically the race data. We will give 2 examples of how we've used the data at Born and PSO, and then we will speak to the governance of our race data. So to begin with, many of you are probably already familiar with Born, but in case you need a refresher, Born Ontario stands for the Better Outcomes Registry and Network. And so we are a registry of data, and specifically for perinatal data. We are a prescribed person under PHIPAA, which means that we can collect and use data without consent. And this collection and use must be for the purpose of facilitating or improving the provision of healthcare. And so, like ICES, we follow very rigorous privacy and information security policies. We're funded by the Ontario Ministry of Health, and we sit within CHEO. Something you may not have known is that within Born Ontario sits Prenatal Screening Ontario. And so Prenatal Screening Ontario, or PSO, coordinates and oversees publicly funded prenatal screening for Down syndrome and trisomy 18 in Ontario. And in the new year, we're excited to launch screening for fetal RHD status in RHD negative pregnant people and alloimmunized fetal blood group genotyping for pregnant individuals with specific antibodies. And uniquely and importantly, PSO is able to use data from Born to quality assure its own screening program to ensure that we're providing high quality screening to all pregnant Ontarians. So this slide will give you an idea of where the data comes from and what type of data is in the Born registry, and also what data is sent to ICES. So you'll see the data we collect spans the continuum of care, right from even before a pregnancy is conceived, receiving data from fertility clinics, through the pregnant individual's journey through screening and prenatal care, labor and delivery, into the child continuum of care, starting at birth, through postpartum follow-ups and NICUs, and into the pediatric time period as well with our new pediatric diabetes education program. And so you can see the green stars signify data that is currently sent to ICES. And we have this one yellow star to signify that in the future, there are plans to send data from the pediatric diabetes education programs. In addition to this, which may not be clear, we do send midwifery data and some RSV data to ICES as well. And a note on Indigenous data. So records for Indigenous people are included in the data that we send to ICES, but the information that would allow you to know which records are from Indigenous people have been rolled up into more broad categories. So you wouldn't be able to identify indigeneity simply from the Born data. So for an example is the data element provider who caught the baby. There is a pick list Aboriginal midwife, but that pick list would be rolled up into a broad category. And Born does have an Indigenous data governance policy that guides all internal and external use of Indigenous data. So in addition to collecting and using clinical data, Born recognizes the importance of collecting sociodemographic and social determinant of health data, as we know that health outcomes are deeply influenced by these factors. And so collection of these data allows for identification of inequities in access to healthcare and outcomes. It can inform targeted interventions and policies. It can support culturally safe and responsive care, and it can promote accountability and transparency in healthcare. So Born does have limited SD and SCH data in the registry. However, we're committed to expanding the safe collection of these data. And so to help with this, we recently conducted a province-wide survey of healthcare organizations to understand the current state of collection of these data and use per the Ontario Health Guidance document. We wanted to understand readiness to collect and share these data, any existing governance and policy practices, how they are using race-based and equity-related data, and their community engagement efforts. And so we're currently analyzing these results, and these results will inform our next steps as to how we can work with other organizations to safely collect these data and have them available in our registry. In the meantime, Born is also including SD and SDH data collection in new projects. So an example is the Pediatric Diabetes Initiative, which I alluded to on the previous slide. And this is where we've partnered with pediatric diabetes education programs across Ontario to collect more detailed sociodemographic and social determinant of health data. And so this helps us better understand how these factors affect children's health and diabetes care, and it allows healthcare teams to tailor support and resources more effectively. And we've already been receiving anecdotal feedback from these diabetes education programs, where by collecting these data, it has informed the services and the care that they give to these children and the family in the moment of their visit. And so one socio-demographic element that is in Born and is sent to ICS is the race of the pregnant person. And so this will be the focus of our talk today. And so this is coming from screening for Down syndrome. And you can see this is a snapshot of your data dictionary in ICES. And you can see here it's recorded as ancestry. And then the definition is ancestry of mother indicated on the requisition. I do want to highlight that the terminology has changed over time. So within our screening program, we have used the word ancestry, the word ethnicity has been used. Now we use the word race. In reality, when we look back at what was collected, because it was white, Asian, Black, it has been race that has been collected. And so we do want to recognize that the definition of each of those three terms is different. And we're working to make changes in our data dictionary to accurately reflect that it's race that we're collecting. So we want to give you some more information about the race data, where it comes from, and the limitations that we are aware of. So as I said, it's collected for multiple marker screening for Down syndrome. And so one type of screen that we offer, race is collected because race is incorporated into the screening algorithm with the goal of making screening more accurate for everyone. And I'm going to touch in more detail on this project in a few slides from now. But essentially it's collected on the screening requisition. It is checked off. Ideally, it's self-reported by the pregnant person. In reality, it's most likely to be ascribed by the provider ordering the screen. So it's checked off on the requisition. It's used by the screening laboratory, and then data from the screening laboratory is sent into the Born information system. So because the data comes from the people who have this specific type of screening, we know that it's available for 70% of pregnant individuals, which represents the uptake of this type of screening. So we have it for 70% of individuals, pregnant individuals in Ontario, but not the remaining 30%. And so we want to note that for the 30% that don't have screening, it might be because screening was not offered. It might have been offered, but it's hard to access blood draw or ultrasound due to geography, accessibility, or other barriers. Or maybe screening was offered to them, but declined by the pregnant individual. And so this highlights the participation in screening. And as a result, the missingness associated with non-participation is not randomly distributed. So in other words, the population represented in our race data in Born is not randomly distributed. Right now we have limited categories. So we ask for Asian, Black, Indigenous, white, and other. We are working in the future to expand the race categories that we do collect to be in accordance with the Ontario Health Guidance document. And so currently that would be Black, East Asian, Latin American, Middle Eastern, South Asian, Southeast Asian, white, another race, and Indigenous, please specify with Inuit, Métis, and First Nations. But for now, these are the limited categories that we have. We do not adequately capture multiracial individuals. For the purpose of screening, if somebody, as an example, if somebody is Black and white, they would be recorded as Black for the screening algorithm, and then therefore would be recorded as Black in the BIS. So just to highlight that some of these individuals are actually multiracial, and we are not capturing all the races that one person may identify as belonging to. I already mentioned these are likely provider ascribed. We know that best practice is self-reported race data. And then finally, through our analyses, we do know that within our race data, there is underrepresentation of Indigenous populations, people from more rural parts of Ontario, people who have lower household income, lower education levels, and those with slightly higher rates of substance use and mental illness in pregnancy. But there is no evidence of underrepresentation of newcomers or racialized individuals. And so all of this context and these limitations are really important for us to understand as we're using these data in our projects and our research so that we understand who is represented in these data and who is not. And so now we'll give some examples of how Born and PSO have used the race data. So, sorry, I'll first start with how we've used race data to explore race-based algorithms in prenatal screening. So as I mentioned, prenatal screening Ontario offers screening for a condition called Down syndrome. And so taking you back to maybe your university genetics courses, perhaps you might remember that Down syndrome is a condition that happens when there are 3 copies of chromosome 21 instead of the usual 2. This is something that happens at conception. Most of the time, it happens completely by chance. And this is related to the pregnant person's age. So we know that as a pregnant person gets older, the chance for Down syndrome to happen increases slightly as well. But we also know that using age alone as a way to estimate the chance for Down syndrome is not the most accurate. And so therefore, we have various types of screening that a pregnant person could choose to have if they want, that will give them a more accurate chance for the baby to have Down syndrome. So one type of screen that we use uses a combination of a specialized ultrasound. There's a blood sample where certain proteins and hormones that the baby and placenta produce are measured. And they incorporate information about the pregnant person, like their age at delivery, if they smoke or not, if they have diabetes that is treated with insulin, their race, among other factors. And so all of that information is put into a screening algorithm, which comes out with a chance for Down syndrome in the pregnancy. So the chance could be 1 in 10, 1 in 400, 1 in 5,000. And so the chances that are above a certain cutoff, so if it is a 1 in 350 chance or higher, you are considered screen positive. It doesn't mean the baby would have Down syndrome, but the chances increased and you would be offered more accurate screening or diagnostic testing. And if the chance is lower than 1 in 350, so like 1 in 400, 1 in 5,000, the result is screen negative. It doesn't mean the baby doesn't have Down syndrome, but the chance is lower, and you're typically not offered further screening or testing. So the part that we are focusing on is the use of race in this screening algorithm. So why is it used in this algorithm? So this is based on observations back from the 1970s, 80s, and 90s, where first screening was done for open neural tube defects, and then screening was being done for Down syndrome. And so it was observed that there were differences in the baseline level of the proteins and hormones that are measured in the pregnant person's blood, and differences between Black and white and Asian and white people. So given these observed differences in the baseline levels, it was decided to adjust for these in the screening algorithm with the goal to make screening work well for everybody. And so at the time, the authors of the papers attributed these differences in levels kind of simply to race. And at the time, it's important to acknowledge that race was more likely to be associated with biology versus how we understand race today as a social construct. And so this is an example of what's referred to as race correction. So in recent years, our understanding of race and race correction has progressed. And so we now understand race to be a social construct with no biological basis, and that observed differences in health and health outcomes may be due to multiple and intersecting sociodemographic and social determinants of health. And race correction in general is rooted in old and discredited ideas that Black people are inherently biologically different from white people. And there are examples across medicine where the use of race has disadvantaged people who are Black. So with these recent calls to assess and remove race correction in medicine, including publications, as you see here, specific to multiple marker screening for Down syndrome, there is a need for us to understand, one, if the decision to adjust for race was based on a racist belief that Black and Asian people were different than white people. 2, how the inclusion and exclusion of race in this algorithm affects performance of the screen. And 3, the impact of collecting race information from racialized people in the healthcare setting. And so to help answer question number 2 about how does including and excluding race affect the performance of the screen, PSO was able to use data from the Born Registry and an emulator to model the effect of removing race from the screening algorithm to see what would happen. And so we have to complicate things, we have two types of this screen that we're looking at. So I'm going to show you two slides with results from test 1 and test 2. And so on this slide, you can see that we're looking at sensitivity and false positive rate, because as you remember for screening, we always want to strike a balance between these two. We want as high sensitivity as possible with as low of a false positive rate as possible. So if we look first at the sensitivity and then at the colored coded column, this is the current screening performance by including race. We don't give you any specific numbers because we're not quite ready to share that, but we have color-coded them from green being highest performance down to red being lowest performance to give you a sense of what we're seeing. So right now, with test 1, if we look at sensitivity, by including race, the highest sensitivity is for the Asian population, and the lowest sensitivity is for the white population. When we remove race using the emulator, we actually saw that there was no change in sensitivity. If we look at false positive rate, currently with race included, we can see that there's the highest false positive rate in the Asian population and the lowest false positive rate in the white population. And if you remember with a false positive for a screen, this causes a lot of anxiety for people. They will be offered a more accurate screening test and or diagnostic testing to get better information, but we certainly want to reduce the number of people that are becoming anxious from this screen. And then, so when we removed race for a false positive rate, we saw that it increased in the Asian population, but decreased in the other populations. So then similarly for test number 2 that we have, when we looked at that one, current sensitivity by including race, we can see it performs best in the white population and then worst in the other population, which would be people that are not white or Asian, or not white, Asian, or Black who are grouped together. When we removed race, the sensitivity actually dropped across all categories. And for the false positive rate, current performance, there's the lowest false positive rate in the white population and highest false positive rate in the Black population, which means more Black people are getting a screen positive result, being offered further testing and diagnostic testing when in fact the baby does not have Down syndrome. When we removed race from this test number 2, it decreased the false positive rate for across all race categories. And so based on these preliminary analyses, we can see that including race does not result in the same performance for everyone. So there's differences. Removing race from the test number 1 could be a solution if the increase in false positive rate for the Asian population was deemed acceptable to that population through community engagement, knowing they'd be offered a more accurate screen as the next step. But our system also has test number 2, and removing race from that, we'd have to consider if removing race from this screen would be acceptable with a decreased sensitivity and a decreased false positive rate. So all this to say, it isn't straightforward. And this requires a lot of collaboration between many partners. And so in terms of next steps, we are discussing these findings with our screening laboratories and determining if further analyses need to be done. We've started community engagement because the voices of Black and Asian populations will be very important in informing what direction we go in. So we've already engaged with a program called Impact through Women's College Hospital in Toronto to seek the perspectives of racialized individuals on their experience in being asked race in the healthcare setting, and if using race is preferable, if that led to a better quality screen, or if race should be removed regardless. We'll also be discussing this project with other organizations and communities representing racialized groups. We're continuing to consider options from a system level. And in the meantime, since race is currently being collected and used in our screening, we're providing educational materials to ordering providers to increase the safety of race collection, which includes explaining to the pregnant individual why race is being asked, how it will be used, and asking the healthcare provider to engage in self-reflection and learning so that they can aim to create a safe space for self-reporting of racial identity. So with that, I will pass it over to Grace to speak about how born data has been used to examine health inequities in Ontario.
Thank you, Dana. So next, we are going to share our research findings using born data to examine health inequities in Ontario. Health inequity is an emerging issue in maternal and child health worldwide. Canada has a universal healthcare system, but it does not mean that every pregnant individual and their child have the equitable access of healthcare. Literature review has indicated that disadvantaged pregnant individuals may lack sufficient access to resources and suffer more stress, which increases the risk of poor perinatal outcomes. Racialized people may face barriers related to language, culture, and religion. There exists systematic or implicit bias in clinical settings. Health equity research on maternal and child health in Canada is very limited, and existing publications report inconsistent findings. In the United States, Black women are about 3 times more likely to die from pregnancy-related causes than white women. But what about in Canada? Unfortunately, it's unclear because Canada does not systematically collect race-based data from individuals to inform analysis on pregnancy and birth outcomes. In the past several years, born researchers have examined many maternal and neonatal outcomes using race and other data at born. The following slides present key health equity findings using born race data in our research, which also indicates that urgent need for comprehensive race-based data collection across Canada to allow us to measure and advance equity in care and outcomes. One important outcome is congenital heart disease or CHD, a leading cause of infant morbidity and mortality in Canada. We examined associations between different maternal socioeconomic status or SES indicators, maternal race, and the risk of CHD among infants. This was a population-based retrospective cohort study, including singleton stillbirths and live births born in hospitals between April 2012 and March 2018 in Ontario. Race variable was identified from born prenatal multiple marker screening data, and covariants were from born maternal and infant data. Born and car data were linked to identify the outcome of CHD. A multivariable logistic regression model was performed to assess associations between maternal neighborhood household income, education level, race, and CHD while adjusting for maternal age at birth. Assisted reproductive technology, obesity, pre-existing health outcomes, substance use during pregnancy, maternal rural residence, and infant sex. This study has been published. We are sharing important findings from this study. So this bar chart shows overall CHD, severe CHD, and single ventricle CHD prevalence by race groups, including white, Asian, Black, other or mixed, and unknown groups. We can see here, across all racial groups, both overall and severe CHD prevalence rates were highest in the Black group. So this table shows association between race to the risk of developing CHD. We used white pregnant individuals as a reference group. This does not mean that white is normal or superior. The choice of reference group was based on statistical reasons. White individuals represent the largest racial group among pregnant people in Ontario, and using white as a reference group provides a more stable estimate. Researchers might also select a reference group based on the research questions and a hypothesis. In this study, we found compared with white pregnant individuals, Black individuals had 40% higher odds of giving birth to a child with CHD while adjusting for covariance in a multivariable logistic regression model. After we found health inequity issue on CHD, we further examined health inequity issues on a number of maternal outcomes, including gestational diabetes, gestational hypertension, preeclampsia, placental previa, placental abruption, preterm birth, spontaneous preterm birth, C-sections, assisted vaginal delivery, episiotomy, third and fourth degree perineal tears, and a number of neonatal outcomes, including low birth weight, microsomia, small for gestational age or SGA neonatals, large for gestational age or LGA neonatals, 5-minute Apgar score, arterial called pH values equals or less than 7.1, hyperbilirubinemia requiring treatment, and neonatal intensive care unit or NICU admission. We conducted a population-based retrospective cohort study that included all Black and white pregnant people who received prenatal multiple marker screening and had a singleton birth in any Ontario hospital between April 2012 and March 2019. Poisson regression with robust error variance models were used to estimate the adjusted relative risk, or R, of adverse perinatal outcomes for Black people compared with white people while adjusting for a number of covariants. So this table presents associations between maternal risk and maternal adverse outcomes. The increased risks were highlighted in red, and the decreased risks were highlighted in blue. We found that compared with white pregnant people, Black pregnant people were likely at an increase of gestational diabetes, preeclampsia, placental abruption, preterm birth, emergency C-sections, and overall C-sections. Of all these outcomes, the greatest impact was on early preterm birth, that births were before 34 or 32 weeks. This table shows associations of adverse neonatal outcomes between Black and white pregnant people. Similarly, the increased risks were highlighted in red, and the decreased risks were highlighted in blue. We found that compared to white people, Black people were at a risk of low birth weight, SGA less than 10th or 3rd percentiles, 5-minute Apgar score less than 4 and less than 7 points, NICU admission, and hypobilirubinemia requiring treatment. Of all these outcomes, the greater impacts were on very low birth weight, less than 1,500 grams, SGA less than 3rd percentile, and 5-minute Apgar score less than 4 points. Health equity on shoulder dystocia is one project that we have finished, and the manuscript is under journal review. Shoulder dystocia is a severe and emergent adverse perinatal complication. Existing literature suggests that the risk of shoulder dystocia varies by race and SES, but research in this area is lacking in Canada. So after we finished the second project, we further examined the health equity issue on shoulder dystocia. We included white and black pregnant people who received the prenatal multiple marker screening and had a singleton stillbirth or live hospital birth in Ontario between January 2013 and March 2021 in Ontario. We used a multivariable Poisson regression with robust error variance models to examine the associations between maternal race, neighborhood household median income, and education level and shoulder dystocia, while adjusting for a number of covariants. In addition, we performed intersectional analysis to examine shoulder dystocia prevalence rates by maternal race, household income, education level at dissemination area. In this study, we found that compared to white pregnant people, Black pregnant individuals had a high incidence of shoulder dystocia across all income and education quintile neighborhoods. This bar chart shows shoulder dystocia incidence rates by race and education quintile in a subcohort of pregnant people having infant with microsomia living in the lowest income quintile neighborhoods. The orange bars show the black group and the gray bars show the white group. We continually observe a high shoulder dystocia incidence rates across all 5 education quintile neighborhoods. Currently, there are several ongoing born research projects using race data. One study is regarding racial variation of mortality and healthcare utilization among infants with CHD, a mixed method study. We have received a Heart and Stroke Foundation grant to support this study. In addition, we are working on infant mortality by race in Ontario, which is supported by Born Ontario. In conclusion, these studies have shown significant health inequities in many adverse perinatal outcomes between Black and white people within the Ontario healthcare system. We have presented the research findings during Black Health Research Day in Ontario and engaged with the local Black community. Our research has provided evidence for decision makers to improve health inequities. There are limitations in our studies. As Dana mentioned, that around 70% of pregnant people received prenatal multiple marker screening in Ontario, which means that around 30% of pregnant people without risk information in the entire Ontario pregnant population. In addition, we are not able to study the effects of different demographic factors, including ethnicity, gender, religion, cultures, immigrant status, and other demographic characteristics in the study population, which may have limited the specificity of our results. Furthermore, due to lack of standardized collection of social demographic and social determinants of health data, we are not able to conduct intersectional analysis beyond race and SES. Born is committed to the safe collection, storage, and use of social demographic data to demonstrate the impact and improve health outcomes for everyone in Ontario. Born is also working toward developing meaningful relationships with Black-led and Black women-led organizations to promote co-design of research and to facilitate knowledge translation to promote interventions and policy changes. I would like to stop here and hand over to Dana. Thank you.
Thanks, Grace. So lastly, we'd like to share our governance work on the race data in BORN. So as we've already mentioned, and it's very similar to ICES, BORN already follows strict privacy requirements of PHIPAA and IPC. But in addition to that, we've also developed a dedicated sociodemographic and social determinants of health data guidance document for all of these data that we have in our registry and to be applied to future data that we have as well. And so this policy emphasizes a few principles. So one is purpose-driven use of these data to identify or measure differences in care and outcomes between and within equity-deserving populations. It emphasizes equitable analytical methods, such as strength-based approaches. It emphasizes best practices in reporting and knowledge translation to contextualize the findings, humanize the results, and prevent reinforcement of stereotypes. And it encourages that all of this be rooted in meaningful community engagement. And so in addition to the general guidance document, we have race-specific guidance. And this further emphasizes principles and practices that are related to the use of race and the race data in BORN. And I can see that our guidance for race data use is very well aligned with ICS's guidance document and framework for anti-racist approaches to research and analytics at ICES. And I also understand that ICS research that uses data from BORN comes back to our organization for review, and we'll be working internally and with your organization to look at this workflow and how our guidance document for race data would apply to the work that you do using the race data from BORN. And then finally, we will be launching a pilot working group in the new year. This pilot group will be comprised of people internal to BORN, members of BORN's Health Equity Advisory Group, as well as key individuals representing Black and Asian organizations or populations. And the idea is that all requests for use or disclosure of race data from BORN will be reviewed by this working group for 1 year. Data requesters will fill out a supplementary race data questionnaire, and then this questionnaire will be reviewed by the working group and using a decision-making matrix that's based on principles for best practice will make a decision to a recommendation to support or not support individual data uses and disclosures. And it's really not meant to be a barrier, but more as a way to see what the data requester has already thought of, what analytical methods they're putting into place, if they've done community engagement, how they're going to reduce harms, and to give more resources and more guidance to further increase the safety of the use of race data. With that, we will take questions. Thank you.
Great. Thank you so much, Dana and Grace. This was really, really interesting and great to hear about some of your work and just dive more into this area, as I think it is definitely something of interest and we get questions about a lot. There are 2 questions in the chat, so I might actually go back to those. And I see there's a hand raised as well, but I'll just go back quickly to the first question that came through in the chat. And Dana, it was actually around your slide 16. And the question was, can you give us a sense of the range between highest and lowest performance, large/small?
Right, a great question. So unfortunately, we can't at this time, just because we're continuing to review the data with our laboratories and determining if we need to do other analyses, but we do intend to share detailed results. So when we're ready to do that, perhaps we could come back and speak to it in more detail.
Great, thanks so much. And then Grace, I think you answered the second question in the chat. It was about how is infant race being determined from the mortality study mentioned, and I think you flagged it there.
Yeah, thanks, Laura. So there are two points. One point is like we use in the infant mortality project, we might categorize infant mortalities and stratified by maternal race. So we use the maternal race directly to examine infant mortality. So I know like we can't directly use maternal race as the infant race, but we can I'm thinking like it's kind of like a proxy of infant race. But another thing, like for infant mortality, maternal race is also is a very important factor, and healthcare access or maybe bias among healthcare settings from like a parent race. So we don't have a paternal race. In bone data.
Thanks for elaborating on that. And I did want to get to the hand raise as well. So Joel, feel free to unmute and go ahead.
Thanks. Just a quick question and then a quick comment to Dana. So Dana, why do you think your trisomy 21 screening performance differs by the racial groups you've assigned if there's no biological effect of race?
Great question. So I think we are still pondering that ourselves. It's probably different. Well, I think we're still pondering that. Based on looking at the baseline levels of different proteins and hormones in the blood, seeing that those are different from Black, white, and Asian, I think we just don't understand why that is the case. And I think we need to do studies that would look at many intersecting sociodemographic and social determinants of health data, maybe like genetic ancestry, like true genetic contributions, perhaps, to try to tease out why there are those differences in the baseline levels to begin with.
Okay, perfect. And I'm trying to hurry to not hog. Do you think sickle cell disease is a social construct?
Oh, interesting. That's related. No, because sickle cell would be related to a specific genetic change in a gene. And while that's more relating to genetic ancestry, as opposed to race, which would be a different concept.
What about twinning preponderance? Let's say you wanted to screen for twinning preponderance. Do you think that's a social construct or has a genetic, racial, as I use it at least, tendency?
That I'm not familiar with, so I'm not able to speak to that.
Okay, no problem. So my problem is when you say race, you reiterate the more modern version of what I've been, understanding for 20 years of research in this arena, that race is definitely not just a social construct. It's a mixed construct. And you made a declaration that it's solely social, and I think that it will trip up the quality work that you're doing by only accepting that what I would say postmodern approach to race. It's much more of a mix of, I think, genetics that are race connected and social constructs. And I appreciate your angle on it being social as well. I don't want to downplay that. But you've made a very bold statement that it's a social construct. And I think that that is injurious to the very individuals you're trying to positively help in the screening or in the prediction and care models that we're all engaged in, including myself.
Yeah, I think it's obviously it's a very complex topic, and I think that race is used as a proxy for many, many different things. And so I'd be curious, happy to chat offline and hear more of your thoughts on this project as well.
Okay, and then my quick comment, which some of you from Born have heard, and that I reiterate, the notion of Asian categorization is dangerous and offensive. to label a woman from India as the same as a woman from Korea
It's very
is
broad.
beyond insubordinate in the use of language, because it really conflates, not conflates, but assembles a solitary group. Now, these are very large members of first and second, third generation Canadians. So it's not that I'm blaming you. I'm not angry. It's that after a couple of hundred papers in this arena, I've learned that there are tripping points with the language, and that my advice is don't use the word Asian and don't study it by Asian, because you will get absolutely opposite effects inside that grouping when you take someone who is from the Philippines and you then compare them to someone from, let's say, Bangladesh or
Absolutely.
another common immigrant group. So I don't want to hog the space, but I'm not lacking the difficulty of using these data, but I am sharing two opinions and, nuances.
Yeah, absolutely. And we completely share the concern that Asian is an extremely broad category and inappropriately broad. As we're working toward expanding the race categories that PSO collects, not just for screening, because we have this question of if we're going to continue to use race in the algorithm or not, that needs to be explored, but recognizing the importance of collecting race-based data for operational uses, for example. We are working toward collecting like East Asian, Central Asian, Southeast Asian, so that we can better represent different populations. And the same can be true.
And even then, just to be clear, women from mainland China and women from the Philippines are so different in their adverse pregnancy outcome tendencies that, having studied this and done it, even that assembly is problematic. These are large immigrant groups to Ontario. So it's a big problem when even they get compressed. And I'm not trying to trip you up. I have been tripped up, and I am trying not to trip myself up again. And that's what I reiterate. Okay, I'm shutting up.
Great, thank you for your questions and kind of the dialogue back and forth there. I think that's really helpful. And, there is so many constructs and contexts to all of this work. So I think it's always just challenging when we work with it. I'm just going to jump over to the Mentimeter because there's a question that came in there, perhaps somewhat similar. It just says, can you possibly expand on how you're looking to capture multiracial individuals in your future data collection efforts, as it seems there's overcounting of certain races given your methodology?
Yes. And so this is something we are currently working out the nuances of how we would collect it from a requisition perspective. And our education to pregnant people and healthcare providers, we would encourage everybody to select as many races as would apply, so that we would be capturing multiracial individuals in that way. A challenge then is how to get those data into the registry. There will be so many iterations of multiracial individuals, so it becomes kind of a person power and technical challenge of properly capturing that in the registry. So that's something that we're still very much considering how we would do that.
Absolutely. And actually similar, because I'm sure it depends too if it's self-reported or provider reported, because similarly, there's a question in the chat. Is there evidence for reasoning that the race collected by PSO is likely selected by the provider?
So it's more that we cannot say that it was self-reported. We don't have a way of measuring this anecdotally, just from working in genetics clinics, working in the prenatal screening system. We know oftentimes, providers will say like, yeah, I check it off, or it might be an admin that is filling out a screening requisition for a patient, and they just kind of check it off based on the physical appearance or perhaps the language, country of origin of the person. So there's anecdotal evidence that there's a lot of assumptions being made about the person's race, which we know, very much means that people who are included in certain race categories in our data, it could completely be wrong. So in our education right now, because we are collecting it, we're really trying to highlight the importance of self-reporting when we have more race categories to choose from, that we hope will help with the self-reporting as well, so that people better see themselves reflected in the options. And there's also will be a blank option saying another race, please specify.
Very helpful. There was a question in the chat, but Grace, I think you've addressed it. The question was, I see paternal ancestry is presented in a small subset of BIS records at ICS. Was that collected for a specific reason? And I think you had answered that question, Grace.
Yeah, thanks, Laura. So AS encounter is a historical one. This encounter already retired. And AP, I think, Dana, please correct me if I'm wrong, like AP encounter is kind of like only has kind of 1% of records. So even for that encounter with paternal ancestry information, we can't use this data element because 99% missing.
Yeah.
Missing.
Okay. Jumping back over to the Menti, and I see we're kind of running out of time. We have a few minutes left. Another question for the Mentimeter is, have the observed differences in hormone/protein levels in blood between races changed over time? If so, have there been any changes in how race has been incorporated into the algorithm?
Oh, really good question. So has it changed over time? I don't have the answer off the top of my head. I know that there is a recent publication by Dr. Tianhua Huang. I don't know, Tianhua, if you're on this call and you would like to speak up, that again demonstrated differences in baseline levels between races, also the impact of insulin and smoking and other factors that are considered in the algorithm. So that was useful because a lot of the other papers are from like 80s and 90s. And have the adjustments changed over time? For some of the adjustments, and I know some of our lab people are on here, they are making adjustments at the lab level, depending on the data they're seeing. I'm not able to speak to more details about that as it's outside my expertise, but if people are curious about it, we certainly can get more information from our lab colleagues.
Mm-hmm. That's great, thank you. I don't see any further questions. I know we're about 1 minute to time, so maybe we'll stop it there. If folks do have other questions, either for our presenters today or more specifically about ICS data that we have, the born data that we have at ICS, feel free to reach out to us. We're happy to direct your questions and answer them after the session. But otherwise, thank you both so much for presenting today. This was really, really interesting and hopefully helpful to a lot of folks as well. As I mentioned, we get a lot of questions about this. So really appreciate you both today. Thank you all for coming. A final push. We're evaluating our series as a whole, as I mentioned at the beginning. So if you have a few minutes, we'd love your feedback on the series and what you'd like to see next year. Great. Thank you so much, everyone, and have a great afternoon.
Thank you very much.
Thank you.